Dear healthcare professionals, in this video, I am going to share with you 7th case in the series on diagnosis. The series of interesting, uncommon, and challenging cases, which I came across while working in critical care. Videos are helpful for all healthcare professionals. I will share a real case that was presented to our hospital's emergency. In this case, the initial wrong diagnosis would have led to life-threatening consequences and mortality. I will walk through real scenario, so you can connect this story with real-life clinical situations. So, let's embark on the story of making the uncommon, interesting, and challenging diagnosis, and how it impacted the patient's management and the outcome. Let's begin with our case. A 58-year-old man presented to hospital emergency after midnight, with history of fall when patient wake up during middle of the night for washroom, and he fell suddenly before reaching to washroom. Initially, case was seen by emergency physician. When the patient arrived in the emergency, he was conscious, tachycardiac with heart rate of around 120 per minute regular, and tachypneic. His blood pressure was around 100 millimeters of mercury systolic. ECG was taken and it revealed the presence of sinus tachycardia. While being evaluated in emergency, he became restless, diaphoretic, with worsening tachycardia, tachypnea, and hypotension. So, emergency physician decided to intubate the patient, and tension pneumothorax was suspected. So, needle decompression done. He was started on vasopressor along with fluid boluses. Patient was shifted for CT scan en route to ICU. Patient was shifted to ICU at around 6 in the morning, with ongoing sedation, paralysis, vasopressors, and intravenous fluid. Plain CT scan brain revealed the presence of 2 small contusions. Patient's past history was significant for diabetes and hypertension on oral medication. His initial labs in the emergency department revealed high blood sugar of more than 400 milligrams per deciliter, serum creatinine 2.5 milligrams per deciliter, and severe combined metabolic and respiratory acidosis. Case was seen by ICU physician at around 8 in the morning. During this time, patient's blood pressure was 80 millimeters of mercury, with multiple vasopressor ongoing including norepinephrine, epinephrine, and vasopressin. It was very clear that diagnosis in not tension pneumothorax. So, why not tension pneumothorax? Patient history of sudden spontaneous fall does not correlate with the diagnosis of tension pneumothorax. And moreover, if tension pneumothorax is the underlying reason, then patient must have been improved after needle decompression and subsequent intercostal drainage placement, which was not there. So, it was obvious that we were dealing with something else. We decided to do echocardiography and called the relative for more information. On echocardiography, there was dilation of right ventricle with D-shaped septum. We did lower limb vascular Doppler, which was positive for deep venous thrombosis. Meanwhile, patient's relatives arrived, and they informed us that he also has past history of thrombosis and takes warfarin. Now the diagnosis was clear to us. Subsequently, we managed him for pulmonary embolism, and finally his life was saved. Prior to starting treatment for pulmonary embolism, he was about to collapse as his BP reached to 40 millimeters of mercury. We could not do CT pulmonary angiography for this patient, in view of critical state and high creatinine. Moreover, there was enough evidence to support the diagnosis of pulmonary embolism, based on history of sudden fall, echocardiography findings, and past history of DVT on warfarin. It is important to know, when suspicion of pulmonary thromboembolism is high, there is no role of D-dimer. What could have been possible if we continue to treat the patient based on diagnosis made by emergency physician, and without trying to know the underlying cause for his sudden fall and deterioration? Not knowing the underlying cause could have led to inadequate treatment and potential mortality. By establishing the underlying cause of fall, hence, by establishing the correct diagnosis, we were able to prevent likely mortality. So, diagnosis of this patient was not tension pneumothorax, but pulmonary embolism. So, establishing an underlying diagnosis is an essential component of treating patients. Healthcare professionals should be cognizant of the differing presentations of common life-threatening illnesses. So when time becomes a crucial factor, as in emergency, diagnosis can be made with more certainty, as it impacts the correct treatment. An outcome, misdiagnosis, or no diagnosis can lead to incorrect treatment, complications, and potential morbidity and mortality. Hope this was an interesting case. If you like this information, please subscribe to this channel for more interesting and challenging diagnosis.